I know, right? Can someone shut these lights off if possible? They might be great. All right, do you guys remember this picture? We're going to go over x-rays. And what I'll do, I'll try to spend most of the time on chest x-rays. The ABCDs of chest films, all right? What you have to do anytime you read a chest film is you have to do it systematically. If you don't do it systematically, then what's going to happen is you're probably going to miss something. So what I always do is the ABCDs. All right. So the first thing I do is A, airway. All right. So let's look at this. Here's your trachea. Remember, in a chest film, things that are dense are bright. All right. So bone, like those ribs, are bright. All right. Blood-filled heart is going to be bright. Things that are dark are going to be air. So even though your spine is back here, see the darkness right here? That's your airway. And can I convince you that this is the carina? So this is the bronchial bifurcation. So here's your right lobe, here's your left main stem. All right, so that's your carina. So this is your airway. So that's the first thing we look at is the airway. All right, B, just to make it easy, we look at bone. All right, so what we can really see in a chest x-ray bone-wise, we can look at the clavicles. All right, we can look at the ribs. These are the posterior ribs, and they're starting to come anteriorly here. See that? Posterior ribs starting to bend anteriorly. And then sometimes we can see little things on the actual T-spine itself. Also, we can sometimes see the scapula. See the scapula here? Here's the edge of the scapula. So we look at bone very quickly. C is circulation, all right? So we look at the circulation. Oh, also B, beyond the bone, is also the breathing. That's the way I remember to look at the lungs. So when we look at the lungs here, here's our lung fields. And do you guys see this kind of haziness? It's not totally dark, right? It's not black. It's haziness. Now, if it was black, Wendy, what do you think that could be? It's totally black. There's no lung here at all. Right, exactly. It's a pneumothorax, right? So, Wendy, I'm going to pick on you because you're pregnant. That's all right. Right? So this is actually the blood of the lung, the vascular supply of the lung. This is the hilum of the lung. And we look to make sure that the lung goes all the way out here. All right? So that's one way we can easily tell for a pneumothorax. That's one of the things we look for in the trauma bay. We look to make sure there's no pneumothorax. I look at the film, I look at those. All right, so C is circulation. So obviously the heart. Now, what do you think? Okay, let's say the heart was huge. All right, what could that be on a chest x-ray? What if the heart's just massive? What could be going on there? Right, one thing is just cardiomegaly, that it's an older patient, it's just a big heart. What else could it be, Lisa? The heart's just huge. It's just filled with something around the heart. Precisely, it could be a tamponade. So let's say we get a gunshot wound or a stab wound to the pericardial area and we see the heart's just massive. God, you gotta think to yourself, maybe this patient actually has a tamponade, especially if they're hypotensive, right? So that's where a chest x-ray can be very valuable sometimes. Okay, D is diaphragm, so I'll look at the diaphragm right here. Very important because I can tell a couple of things, and I'll show you some examples. One is that we can see if there's fluid accumulating in the costophrenic angle. This is called the costophrenic angle. All right, costo meaning the ribs and then phrenic meaning the diaphragm. The other thing we can see in the diaphragm, what if the diaphragm is really high, right? Or if we don't really see a diaphragm and we see a big stomach bubble up here. What if we see a stomach bubble up here? Doris. Exactly, diaphragmatic rupture. That's exactly right. Those are the types of things we do. So A, B, C, D, and then E is everything else. So look, for instance, if we can see where our endotracheal tube is, look to see where our central lines are. Sometimes we look to see our feeding tubes or NG tube. All right. So that's what you should, I think, always in general try to do when there's a chest x-ray up. Go through the algorithm, ABCDs. All right. I presume this is what's going to happen here. If I just do this, it will hit next. All right, great. Okay, let's do this. Kathy, let's pick on you because I love all of you, but sometimes I raise my voice at Kathy because I'm frustrated. So this is your chance to get back to me. And Kathy, we hug it out a lot. So let's do ABCDs, all right? A, can I convince you that the airway is right here and it looks normal? It's hard to see also because it's being projected on the screen, so it's sometimes hard to see. All right, what do you think of the airway, Kathy? It's pretty much normal. I'll just tell you, it looks pretty much normal. There's the airway right here, and the carina is probably right here, but it's hard to exactly see. All right, let's go to B. Let's go to the bones. The bones are basically normal. All right, let's look at the breathing now. Let's look at this lung first. Kathy, what do you think? Does this lung, does it look like there's white stripes going all the way across? Okay, good. I agree with you. How about this lung right here? Does it look like the white stripes go all the way across? It doesn't, right? There's a lot of black right here. What do you think that is?
There's air.
That's right. It's air that's outside of the lung. All right, because here's the lung ends here, because all these white stripes end right here. So see this line? You guys see that? Everyone see that line? Yeah. All right, and then you see air back here. That's a pneumothorax. All right. Now, can someone tell me what the definition or the differences of a pneumothorax and a tension pneumothorax? What do you think, Gina? What's the difference of a tension pneumothorax?
Well, in a tension you would see maybe the next step deviation.
That's exactly right. In a tension pneumothorax on X-ray, you see deviation. From a physiologic standpoint, a tension pneumothorax, what we call tension physiology, is when you actually, because it's so deviated and pressurized, you actually get decreased venous return to the heart, and therefore what can happen? Precisely, a patient can become very hypotensive and all of a sudden get into hemodynamic collapse. So I always ask the medical students this: patients don't die from a tension pneumothorax because they can't breathe. They die because they don't get vascular return to the heart, and hence hemodynamic compromise, right? Okay. So I think I've actually got, all right, this is just a close-up of this. So see the white lines coming out to the end of the lung here? See that? There's the lung edge, and there's the air. All right, remember, black is air. So if there's a lot more black going on, you've got to think about something that could be happening. All right. Okay. Who said whoa? All right, Gina, what's going on here? Just go ABCs. Again, anytime you see a chest X-ray, just take a step back and say ABCs. So let's talk about airway. Where's the airway? It's totally pushed over, right? See the airway right here? Totally pushed over. The bones are going to be okay here. What about the B, the breathing? This looks not black. This looks really black. All right, what's going on over here? This is the tension pneumothorax. All right, now I want to show you something. Remember I was talking about the diaphragm and the claustrophrenic angle? Look how it's like totally gone. Right? We call this a deep sulcus sign. It's deep. It's all the way gone. It's totally gone. Everything's pushed over this way. Heart's right here. It's all pushed over. All right? You can imagine. So did you guys see that tension pneumothorax there? It's pretty bad. All right? Now let me show you a couple other things here. Look at. Thanks. Okay. Do you see all this air here? All right. So that's air. That's called subcutaneous emphysema, and that's crepitance that you're going to feel clinically. All right. And obviously you can see, because this heart is so pushed off to the side there, that you're going to see the patient's going to get hemodynamic collapse. Now, in theory, we never want to have a chest X-ray like this. Right? So we should recognize this before this happens. Now, I made a mistake in 2006 in a kid in the ED who everyone kept telling me to write nasal intubation because they saw the endotracheal tube over here, but it was actually in the trachea just pushed off to the right. We sent the kid to Children's, and he did all right, but God bless it, I screwed that one up. I should have put a chest tube in him and decompressed his tension pneumo, which he had. So I almost, anyways, wasn't a good day. All right, now, what's going on over here? Isn't that weird? We've got all this stuff happening, and we've got, I'm going to have to call Cosatini here. But you see why that's hard for, why is all this white stuff here? Remember, white is dense, black is air. So the air should be going down all the way over here, right? But we've got all this white stuff. What's happening over here? That's a hemothorax, all right? So we've got, I know, I'm sorry. You guys are like my extended family, so I don't really care what I say. All right, so you see all that blood there? All right, so that's probably of a hemothorax. All right, now I put this on because I want you to see this is very interesting. All right, this is pretty normal here, okay? Do you see the difference? Can I convince you there's a difference? All right, what's going on here? Now, think about this now. All right, remember, when something is brighter on a chest X-ray, it means that there's something in there that's not air. So if there is not as much air being visible on a chest X-ray compared to this side, what's in here? Now, I'm going to show you something. This is a clear hemothorax. It's actually probably atelectasis too, right? Because but this is clear hemothorax. all right? But you got to tell me what's going to be, this is a trauma patient now, what's going to be causing this that's going to be more dense than this? Not a contusion, because a contusion is going to be, first of all, it's going to happen a little bit later down the road. You'll get the contusion at the injury, but it'll start getting brighter down the road. And we'll have an x-ray on that. But why is there, what's going on here?
Is it not ventilated?
See, this is where, okay, there's no wide mediastinum here, though there might be a little bit, but I'll tell you something here. This is actually hemothorax. Now, why does that look, it's brighter. Something's got to be making it brighter, right? This patient didn't all of a sudden start growing bone. So something's got to be making it brighter. And there's only one thing that's going to make it brighter. It's not this, because this is a patient who's actually upright. So the blood is going to be viscous. This is a patient who's flat, so it layers out. And this is what I constantly tell the residents, look at these films, because you're going to think, oh, there's no fluid here. Remember I was talking about the claustrophoretic angles? Because it's all layering out this way. You can actually get almost a liter of blood that layers out like this in an acute trauma patient before it starts actually giving you the meniscus sign over here and all that kind of stuff. All right? That's, I think, kind of an interesting one. That's me. All right. Now I'm just going to go. Who said that? Good. Where do you see them?
I can see those.
Right. You see these? These are posterior rib fractures. Now, Joel, did you say pulmonary contusion? All right. Now, why is this lighter than here? Because this lung is in fact contused. And you see how it's brighter? It's not brighter all over the place. See, this lung is actually pretty much kind of normal aeration, right? This is normal side. See, it's about the same color. It's just Sesame Street. Which one of these is not like the other? Which one of these is not like the other? This ain't like this, all right? So this is actually a pulmonary contusion because you can see it outlined nicely, all right? And clearly the rib fractures are here. What's all this black stuff? Remember, black is what? Well, yeah, exactly, Sandy. This is also clear, right? All right, does that make sense? Okay, what's this? Exactly, the chest tube. Now, what I would do if I had more time, I'd pick one of you, probably Claire because she's not paying attention, and I'd do ABCDs. And I could do ABCDEs, and when you get to the E's, everything else, you'd notice that there's a chest tube in here. All right? All right, now. Good. That's E, everything else. Let's jump to C, circulation. All right? Heart pretty darn big. All right? Whoa. That's the wide mediastinum. Okay? We generally like to have 8 centimeters or low or low. Good, Jim. CT angio. We like to have 8 centimeters or less. Okay? This is probably about 10 centimeters, 12 centimeters. The aorta that we normally see coming down nicely is blunted. It's gone. All right? This is very concerning. If I told you this patient had a head-on MVA, see, this is a problem. I see this, it makes my night so much longer because now I got to get a CT angio, and now we got to like stabilize the patient in the ICU, and I just want to go back to sleep sometimes. So when I see this, it makes me really nervous because I know, one, this patient has a problem. But if they're stabilized, it's not that big of a deal, right? Because we can wait. We don't have to rush and operate. Get the blood pressure under control, assess other injuries, make sure there's no intracranial hemorrhage, see if this patient can get an actual endovascular technique versus an open. So we've got time to play. Remember, the patients that die from these die in the field. All right? Most of the patients that die from an MVA outside of head injury, they die from a ruptured thoracic aneurysm, or excuse me, a ruptured thoracic aorta. All right? Because they die in the field. Those patients that get to us, they have enough of the hematoma where it's tamponaded, where they're actually able to be stabilized. Right? So it's one of those things where it's obviously an emergency, but on the other hand, we've got time to just chill and assess the injuries and stabilize the patient. All right. I'm going to just show what it is here instead of picking on you. What do you think this could be going on here? Which one of these things is not like the other? This is normal. You just can't tell because it's a bad film. Good. So you don't really see much of a claustrophrenic angle here. So if you see that, what are the possibilities, Joel? You said there's no claustrophrenic angle here. So what are the possibilities that's going on here? Good. So one is possibly an abdominal wall hernia or a diaphragmatic hernia. That's a possibility. How would we diagnose that? Good. Absolutely right. Put an NG tube down, and then you might be able to see it in the left chest. That's one possibility. What else could be going on here? And the mechanism of the patient's important too.
Abdominal aneurysm.
No permanent aneurysm. Well, it could be bowel. What else? What if it's the lung? What could be making the lung brighter? We talked about it earlier. A contusion, right? Blood fills up and you get a pulmonary contusion. That's a possibility too. But Joel's correct. We put it in G-tube down. We see it curled up over here, and in fact, we see a diaphragmatic rupture. All right. There's also probably a contusion here, but it's also probably atelectasis because now everything's being pushed up. And so what you're seeing back here is the lung is being pushed up, giving you atelectasis, and this is probably intra-abdominal contents, specifically stomach. All right, and there's the G-tube curling up in there. All right, this is a dumb one. It's not a dumb one. It's a good one. This is one. All right, Sandy, I'm going to pick on you. This is going to be A, B, C, D's are correct. E, everything else is not correct. Now, it's a little tricky here, but tell me what else is not. What else is in here that shouldn't be here or that is improperly positioned? And this is because you were laughing. God damn, you guys are good. That's why I like working here. Wait a minute, though. Did you give an assist, Neil? All right. That's exactly right. So you can see the central line is the subclavian. It should be going down in the SVC into the heart, right? Look at it going up. All right, so that's an E, everything else. That's just another kind of ICU-related chest film. Okay? This is kind of an interesting one. What's going on over here? All right, this is a non-trauma x-ray. Someone said the heart. What about the heart? It looks pretty darn big. All right, so let's take this. This is a patient who is in our ICU who has a little bit of hypoxia going on. We get a chest x-ray. You see a clearly enlarged heart. What do you think is going on in your mind here? Rose, what's happening with the patient? And why is the patient becoming hypoxic? And what are the chest x-ray findings? The heart, the hint is the heart.
It's bigger than it should be.
The heart is bigger, yeah. Good, and therefore, what can congestive heart failure do?
Yeah, you can get some pulmonary edema.
Do we see any evidence of that in the chest x-ray? Absolutely, excellent, guys. You see how this is all kind of edematous? This is fluffy. The vascular markings are bigger than it should be. Right? That's classic. That's a classic pulmonary edema, especially the fact that you've got this huge heart. That's exactly right. All right. Okay, again, I got to run here, but this is ABCDs. All right, so airway's fine. You can actually see this patient's intubated, which isn't surprising. Why is this all white? It's not trauma now. This is a patient in the ICU. Precisely, ERDS. Bilateral puffy infiltrations, not puffy vasculature or edema, infiltrations. This just craziness all the way around. All right, and then this is just atelectasis right here. All right, that's pelvis. I'm going to skip that. I'm just going to quickly show you. Here's our FAST. Did you guys know what a FAST is? Right. I mean, I know you do, but it stands for Focused Assessment Sonography for Trauma. Can someone tell me what we're looking for in a FAST? I know you guys know this, but that's it, right? That's exactly right. And everyone said the same thing, fluid. That's all we're looking for in a FAST. Now, the advanced sonographers, and we're trying to do, we can do other things, like look at IVC diameter and all that kind of stuff. So but FAST and everyone else, Focused Assessment Sonography for Trauma, is looking for fluid and fluid only. And we look at really 4 areas: the left upper quadrant, the pericardium, the pelvis, and the right upper quadrant, left upper quadrant, pericardium, and the pelvis. That's it. Now, really quickly, there's only 4 images here. This is the left upper quadrant, the right upper quadrant. This is normal. Here's kidney, okay, K. Here's liver, L. Here's diaphragm, right here. This is normal. In sonography, dark is fluid, all right? I don't see any dark here, but I do here, all right? That's fluid. This is called Morrison's pouch, some of you may know that. All right. This is the bladder. Now, this is why we say the bladder has to be filled. Sometimes if it's like an old lady that falls down, I don't bother, all right, because it's not, they're not going to have intra-abdominal fluid, so I don't bother. But this is why the radiologists really harp on us to do this. And that's because only with the bladder filled can you really see the free fluid here. And that's free fluid. All right, so there is a method to the madness for having a bladder fill. All right. All right, this is the left upper quadrant. This is spleen. This is the diaphragm. See the fluid around here? All right, so that's a positive fast as well. And then finally, this is the pericardium. This is noise. Here's the heart. Here's the pericardium. What's this dark stripe? That's fluid. Okay? Does that make sense to everyone? All right, I have to run. I'm sorry we couldn't spend more time on this.
Thank you.